everybody for joining us for the second installment of this fall 2021 Faculty Forum. And we are really happy to have Dr. Michael Walsh here with us today as the speaker. And of course, the title of his talk is on the slide here, so I won't repeat. But let me give you a little bit of background about Dr. Michael Walsh. So he was awarded his undergraduate degree in biology at Lancaster University in the United Kingdom and stayed to complete his PhD in biomedical engineering. He moved to the United States in 2008 as the Carle Foundation Hospital Bachman Institute Fellow at the University of Illinois at Urbana-Champaign. In 2013, he moved to the University of Illinois at Chicago as a faculty member in the Department of Pathology. He then moved to join us here at the Department of Material Sciences and Biomedical Engineering in the summer of 2020. So thank you very much.
Cool,
Michael,
thank
for
you.
joining us. And
cool, thank you. Good afternoon, and thanks for the invite to speak here. Can you hear me okay? Yep, perfect. Okay, so today I'm going to talk about some of the research in my lab, which I've called the Spectral Pathology Lab. Some of this work is from my previous institution, and then I'm going to talk about some of the newer work that my students have been working on since spring. Okay, so what I'm going to talk about today is a little part of what we've been working on for the past almost 10 years, which is developing new biophotonic approaches towards improving medical care with a focus on disease diagnosis and prediction of patient outcome. So today I'm going to talk a little bit about the development of this technology with a focus on cancer and fibrotic diseases, and I'll speak a little bit about the importance of this as well potentially in the transplant setting. So the overall goal of the research I do is to extract additional diagnostic or prognostic. So prognostic means predictive information from tissues, from patients, so that we can better guide either their treatment or their monitoring or their diagnosis. So I want to just talk a little bit about what is the current gold standard. So the current gold standard in medical care involves something called pathology. So you may have heard of pathologists. Pathologists are the people who make the diagnoses. So anytime you go to the doctor and you have a sample taken, be it tissue or blood or serum, saliva, that will go to the pathologist. And the pathologist is basically there to determine whether there's an abnormality, and if there is an abnormality, to get as much information from that sample as possible. So for solid tissues, if you're suspected of having disease, so practically any organ in the human body, the first step is you'll have a biopsy. So some of you may have had a biopsy, and this involves taking a needle core biopsy and then taking a little piece of the tissue to see is it normal or diseased. The tissue is then fixed in typically formalin, and this basically stops it from degrading. It freezes it in time. So you can literally go back to these tissues decades later, and they will look exactly the same as that moment it came from the human body. The second step is to embed this tissue in paraffin, and what this allows you to do is slice the tissue very thin, so you can look at each of the different cells within the tissue, and then you stain the tissue. So tissue, even though I can see you all today, tissue actually, when it's sliced very thin and down a microscope, doesn't have a lot of contrast. You can't see a lot, and you can't make a diagnosis. So the type of stain you use depends on the tissue and the disease of interest. So I'll talk about that in a few slides. So the typical gold standard is a pathologist, so a human being, makes a diagnosis using a light microscope and then looks at the tissues. And you'll see a lot of examples of normal versus abnormal and what they have to do. There's a lot of, I just want to briefly mention, there's a lot of focus on developing artificial intelligence and machine learning for taking these visible images and replacing the pathologist with a computer algorithm. So if you saw the news this morning, actually, there is the first ever FDA-approved prostate cancer highlighter algorithm that's just been literally approved. I think it was yesterday. So the idea behind my research is, rather than using this sort of conventional technology with visible microscopy and a human being, is to use a complementary imaging technique, which rather than using light, can harness the inherent biochemistry of the tissue. And I'll talk more about that. So the typical process for a pathologist is to do molecular and structural analysis. And they do this using stains and this very sliced, so this is about 4 microns thick, sliced tissue and then they look. Can anyone guess what organ this is? Any of the undergrads know? Kidney. Yep, so this is a kidney, this is glomerulus. So they're basically looking, is it look normal? Are the cells in the right place? Are the quantity of the cells right? Are the thicknesses the correct? So what we're interested in using a complementary technique called infrared imaging, and this potentially can offer advantages over the current clinical process using light microscopy. And as I said, we've really sort of focused on improving diagnosis, and my real focus over the last few years has been more on the prediction of outcome. So rather than trying to replace a pathologist, how do we get more information back to both the clinician and to the patient? Okay, so why mid-infrared? Why have I spent 15 years of my life working in this little part of the electromagnetic spectrum? So infrared offers significant advantages over other techniques. The first being there's no need for stains or dyes. This is time-consuming, it's expensive. There's issues with things not staining correctly, false positives, false negatives. It's completely non-destructive, so you can do other types of analysis later, so it's a very good adjunct. It's completely quantitative, so if you want to know exactly how many cell types are, the volume of cancer, it's completely digital, so you can very quickly get that information. Importantly, it fits into the current clinical workflow. So one of the things I spent a lot of time doing in Chicago was developing the computation and the hardware and the software to be as sensitive to the current practice so that clinicians don't have this dramatic change in what they have to do, because that's not going to work. And I think most importantly, it's a novel route to additional biochemical information that can't necessarily be harnessed using light microscopy coupled with staining. So there's two major questions that I've been trying to address. The first is, what are the diagnostic challenges? So we tend to think if you go to the pathologist or the doctor, they're going to give you a definitive diagnosis. You have this type of cancer, it's this grade, it's this stage. But it's often not quite correct, and the accuracy can be as low as 70% and actually lower for some types of cancer. So I'm not going to talk about it today, but there's a paper we published 2-3 years ago, and we're actually working on one now, looking at two types of cancer that look very, very similar down the microscope, and yet they have very different trajectories and require different treatments. So hopefully by the end of this month, I keep saying this, but we have a paper on oncocytoma and chromophobe, which are two types of kidney cancer. They look very, very similar, but they have very different outcomes. And we find that we can actually use this technique to differentiate. So the second way I've been really interested is, where is there a need for additional information? Where do current techniques cap out? Where can we give additional information that even the pathologist can't currently provide? And I think that's a good niche to have, sort of like mass spectroscopy in clinical pathology, where the current techniques are kind of limited. So, as I said, the mid-infrared is part of the electromagnetic range. The traditional microscopy uses the visible part of the electromagnetic spectrum, and you take the light, it passes through your stained cells, and then you collect the X-ray radiation. And I know Blake is in my 221 lab in an hour, and we'll actually be doing some microscopy as well, regular microscopy today. So we're interested in using this region, which is the mid-infrared, so it's a little bit longer wavelength. This goes through our cells and tissue. In this case, we don't stain the tissue, it's completely unstained tissue, we just use a special type of IR slide. And in this case, we collect the exiting radiation with a spectrometer. So the reason for this is, with visible light, obviously our eyeballs can see it, a pathologist can see it, and looking at a microscope, mid-infrared we can't, we don't have those receptors. So we use a special infrared sensitive detector. So why mid-infrared? Why did I get stuck in the mid-infrared? So it turns out mid-infrared is extremely useful for biological samples. So if you shine mid-infrared through cells and tissue, different regions of the mid-infrared will be absorbed by different biomolecules. So it allows us to measure a whole range of biomolecules, so proteins, lipids, carbohydrates, glycogen, collagen, and these are all really critical biomolecules which are a part of disease processes. So essentially, you shine our light through, and we end up with an absorbance spectrum, or something we like to call the biochemical fingerprint. So the basic theory behind this is that this fingerprint will be altered between different cell types or different disease states. So these peaks correspond to different biomolecules. So what we find is this signature is unique to different cell types, and we can use either very simple analysis or more complex analysis like machine learning to be able to use this fingerprint to predict what a category belongs to, and I'll talk about that as well. The other thing is, if you're interested in looking at how a disease progresses over time, you can track how this chemistry changes as well, which can give unique insight into disease processes. So one example we published last year, 2020, was looking at lung fibrosis progression and remission in mice, and we found that we could use this to sort of track remission, progression and remission in a label-free manner. So the nice thing with infrared, so I started my PhD in 2005, and we didn't even have these detectors available. So the technology's changed massively over the last 15, 20 years. So the idea behind IR imaging is you can put infrared in where you can use visible light, like traditional microscopy, and flip and do mid-infrared light. And this goes to a special infrared sensitive detector. So these detectors have been a huge advance because of the military, actually. The US military developed them for weapons missile guidance systems. And they were declassified in the 2000s, and they're still actually only available in certain countries still. So we actually have we actually have two technically in the lab. So the idea is we acquire an image. So this is just like an image in your iPhone or your Android phone. The difference being that this image of the sample, rather than having 3 channels, so a visible image has 3 channels, a red channel, a green channel, a blue channel, and then the combination of these is the color we see, typically 3 channels. In mid-infrared or any type of spectroscopy, every channel, so every pixel has all of that biochemical information within it. So you have typically thousands of channels of information. So for example, if you're interested in, say this is cancer and this is normal, you can click, extract the spectra and find out what is the fundamental biochemical difference between those. Is there an increase in lipids? Is there protein conformational changes? Is there some sort of glycosylation? So that's sort of the principle for everything we work on. So one of the really nice things about imaging is we get the entire tissue. So in the past, a lot of photonics has focused on bulk measurements. So you get a measurement and then relate it to a disease. The problem is, this is a good example here, where you have a lot of different cell types and tissue structures. So you have to really know where your source, where your signal is coming from. So one of the things I'm not going to talk about today, but we spent a lot of work on has been really systematically going through and seeing where are the most diagnostic signals, where are the most prognostic signals. It's not always where you think. And we published a paper a few years ago where we were interested in looking at different types of liver cancer. And one of the problems was if we looked at they're called hepatocytes, the cancer cells, there's so much interpatient variance and so much interdisease variance that it wasn't going to work. We couldn't find a robust pattern. But when we looked outside of that at other structures, which were less involved but still part of the disease process, we could actually find diagnostic markers which were more robust. And I think I talked very briefly about that. Okay, so I want to give 3 examples of how we've applied mid-infrared imaging, 3 distinct different examples of how we've applied mid-infrared imaging for different applications. So the first thing is either cell typing automation or disease automation. So as I said, you go to the pathologist. So this is an example in the breast. You go to the pathologist, they'll take a biopsy. And the typical first stain they will do is something called hematoxylin and eosin. And this is that sort of stereotypical pinky purpley color. And it gives you kind of a good overview of all the different cell types and structures within the tissue. Next, you may, depending on your expected disease, take a whole bunch of other sections and stains. And these can be quite expensive. These are immunohistochemical stains. They use antibodies. So you'll take sections, and then a pathologist, who we haven't got any pathologists in the audience for once, so I can say this, who are paid a huge amount of money per hour, they have to sit down and make diagnoses based on the patterns and what stains and what doesn't stain. So one of the things we can do is, rather than taking multiple sections and multiple stains, we can use the infrared image and the inherent biochemistry to automatically segment out the different components of the tissue, just by dialing into this chemical information. So let me show you how do we do that. So the first thing we do is we create training sets, and these training sets are where we have ground truth. So this can be where we have an annotated image of cell types or disease types, or maybe something like outcome of an organ. And then we go through and create a training set where the spectra are derived, which are the ground truth. So what we know the spectra should look like. So one of the things about spectroscopy, particularly in the mid-infrared, is the spectral changes are very, very subtle. They're very, very subtle. And that's why things like multivariate analysis and machine learning really help, because we can really dial into those very subtle changes. Okay, so what we then do, and you can do this in a multitude of ways, we go in and identify potential spectral features which may be diagnostic. So just to give you an example, this orange here is mucin. So if you imagine you use a spectral metric such as area under the curve between 1140 and 1000 wave numbers, the value for mucin is going to be much higher. So you can use that to predict what a spectral pixel is. And then there's a whole bunch of sorting and classification, optimization, all this type of stuff. But just to kind of give you an overview of how this works, you create a training set, and this training set, depending on the type of approach, will recognize what all the different classes are, if it's cell types or diseases, and what the spectra should look like. So essentially what you do is you feed in an unknown image. So this is a single pixel. And then you compare this spectra to your training set. And we've used random forest neural networks. Are you familiar with that? Bayesian. There's a million ways of doing it. But essentially the overall principle is it compares it to the training set and then makes a classification. So in this case, it says, OK, it has these spectral features. It looks like this class that we encountered earlier. Therefore, we're going to classify it as green. So what that allows us to do is rather than taking multiple sections and multiple stains, you feed an image in, it goes through every single pixel and assigns a class. So this is a nice example here where rather than having someone have to look down and say, this is necrotic, this is stromal, this is more collagen, it will automatically do this. And we can do this for cell typing, and we do this for diseases, cancer versus no cancer. So the second type of thing we can do is something called stainless staining. So one of the problems with this approach is you lose a lot of the definition. It kind of just blankets a single class. So we want to see, could we actually replicate staining itself? So if you're familiar with artificial neural networks, that's the approach we use here. But essentially, the principle behind this is we take our infrared image with our many spectral channels, and then we take our stained image, in this case, our H&E with our 3 color channels, and then we very carefully overlay them. And a neural network will train for changes in the color with changes in the infrared spectra. So this is this isn't real data, this bit here. It's just sort of an example of how it works. So for example, the neural network determines that an increase in the red channel, say the red channel gets darker, this is vibrating, and it corresponds with an increase in say 1080 and 1030, then the neural network will be able to recapitulate that coloring. And it actually works really well. So it allows us to digitally stain the tissue. So this is a nice example here where on the left is the real H&E stain. And you can see a nice example actually of where the stain didn't permeate to the end. It was an artifact. With infrared, we're able to do this because there is no stain. It's just the inherent biochemistry of the tissue. The tissue is fixed. It's going to look the exact same however many times you stain it. We can also do this for other types of stains, things like Mason's trichrome, smooth sulfur actin, which, if you're familiar with reactive stroma, is a reactive stroma marker or a mesenchymal marker. We're actually, with David, who's now a professor in Houston, we're actually working on a follow-up to this as well, which is a lot nicer. Okay, how are we doing for time? Okay, 12:27. So one of the projects I've been working on for quite a while has been in the transplant setting. It was kind of an area I fell into. It wasn't somewhere I anticipated working. One of the issues in transplant is we've got an increasing number of people who need transplants, particularly in the kidney setting due to diabetes. And people typically wait for about 5 years on the transplant list. I actually had a friend of mine who was on the transplant list who passed away last year just because she hadn't got a kidney quick enough. The waiting lists are ever increasing. And so this is the number of transplants, and then this is the number of people receiving transplants has been flat. So people are on there for 5 years, typically, and then are going to dialysis 3 times a week. It's very burdensome. So one of the things we wanted to do was focus on really 2 areas. One area we've done, and then one area we're going to do here. The first is trying to identify those patients who had a transplant and make sure that they retain their organ. Typically what we find in the transplant setting is people would get a new organ and then they would kind of disappear off. Clinically they feel really healthy, they're off the dialysis, and then within a year or 2 they're back with clinical symptoms and they've lost that second organ. So we've done this I'm going to talk about kidney. We published 2 years ago in Journal of Transplantation where we show we could do this in the heart actually for 2 major types of rejection in the heart. Okay, so the problem with transplantation is there's a number of issues which can occur post-transplantation. And one of the recurring themes, particularly in kidney, is by the time there are clinical symptoms, by the time people have some sort of symptom of kidney failure, it's too late. They've already done significant damage to the organ. Kidneys are particularly problematic because you don't tend to have any symptoms of kidney failure until your kidney is below 15% efficiency. So you could be at 20% and have no idea. Unless you're going in getting tested, you have no clue. And even my auntie actually has got down to 4% before she knew she had problems, just because especially as you get older, they tend to be fairly non-specific symptoms, and then it's very severe. So there's two types of complications which happen in the kidney transplant setting, which we were looking at. The first is recurrence of diabetic nephropathy. So these are patients who lost their original kidney due to diabetes. This is the leading cause of kidney failure and end-stage renal disease in the US. The second is something called tubular interstitial fibrosis, which is where you get this deposition of fibrosis between the tubules. It's an inflammatory response, and that can occur due to multiple etiologies. Both of these have the issue that the changes in histology are often too late. It's very difficult to predict the outcome, and we really need to be able to identify those patients who need stratifying, who need identification for either closer surveillance or more aggressive treatment. And one of the problems with tubular interstitial fibrosis, and we're actually, I'll show you the study, we're currently working on this now in my lab, is it's very difficult to tell the etiologies, and it can be too much medication, too little medication, it can be inflammation or infection, and if you don't know, you can't treat it, and it's a real balancing act for the clinician. So very quickly, one of the things we published a few years ago in Kidney International was we wanted to see, could we detect a biochemical change associated with a person being diabetic in the kidney? So we wanted to find a pure diabetic signature. These were in non-transplanted patients because transplant gets very messy. What we found is that the patients with diabetic nephropathy had a unique signature. And we could actually even just use a very simple ratio of 1030 to 1080, and they had an elevated 1030 to 1080 ratio, which was associated with diabetes. And this is the sort of traditional way of doing it using something called the mesangial fractional surface area. When we do something called linear discriminant analysis, which some of you may be familiar with, what we found is we could classify out the different types of three classes, which was interesting because we had the diabetic patients who had diabetic disease, which was verified by the pathologist. We had normal diabetic. So these are people who did not have kidney disease but had diabetes. And you can see biochemically the different. Sorry, I didn't really explain this. And then we had normal non-diabetic. So these are called, we sort of flip back and forth between PCA and LDA. They're quite similar. These are called scores plots. Essentially what these are, and I can go in more detail if you're interested, but essentially what these are is the distance on the plot is related to dissimilarity. So the further points are away, the less similar the chemistry is. So when they group together, it means that they have an underlying biochemical pattern, that biochemically they're very similar. So it allows you to see, is there something biochemically that is different between the two groups? Does that make sense? I can talk about that more at the end as well, the idea behind PCA and LDA. Okay. But it was interesting because we did find that even the patients without kidney disease, there was increases in glycosylation associated with a normal healthy individual whose kidneys look perfectly fine. So we did a small study where we wanted to identify patients who had had a transplant. So this was in the transplant setting. And we took 5 patients who had an early biopsy about 3 to 6 months in, and then they had a subsequent biopsy 24 to 36 months in. 3 of these patients had recurrence of diabetic nephropathy and 2 did not. What was interesting is when we looked at the chemistry of the recurrent patients, they were different, as you'd expect, from the non-recurrent. But even when we looked at the very earliest biopsies, we found that the chemistry, even a few months in, was different from the chemistry of those who would become recurrent. So it tended to suggest, and we've been doing some extra work as well on this, that even in patients who had no visible changes from the pathologist's eyes, had something biochemically occurring very, very early on. It actually matches with some new stuff in mass spectroscopy as well. We did a similar kind of study where we looked at tubular interstitial fibrosis. And this is PCA. This is an unsupervised multivariate approach versus PCA-LDA, which is supervised. In this, we did a similar study where we tracked patients over time. Some of these had progression of fibrosis, so they had development of fibrosis, and some did not. And again, we found the non-progressors versus the late progressors had different biochemistry, even using a non-supervised approach. And again, when we used PCA-LDA, which is supervised, we were able to separate out the non-progressors from the progressors. And what's important is if you look at the half symbols, these are again from the earliest biopsy where there was no indication from the pathologist that there was an issue. We've actually got a whole bunch new tissues as well from the pathologist that we're currently scanning through, which is Zach Caterer, if you know Zach. Okay. I'll quickly flip through this. We're also working on liver disease. So kidney and liver has been my two major focuses. There's two major types of liver disease apart from hepatocellular carcinoma, one being a non-alcoholic steatohepatitis. It's a massive problem in the US. It's becoming a really big killer. And this is also sometimes, it's a slightly different definition, but it's essentially the same as something called fatty liver disease, which you may have heard of, or Nephropathy. And this is where people have very high fat and high carbohydrate diets, and you get deposition of fat within the liver cells, and then that causes inflammation. And there's a whole bunch of different grades. So we've been doing work, particularly with image analysis. I'm not going to talk about this today. And we're actually working with Dr. Rahul Gomes, which we actually got an ORSP grant for. We just started using our images to be able to do classification with something called convoluted neural networks. What we found is we could separate out the different grades of NASH from fibrosis and hepatocytes. So what was important here was we found that actually different grades had better segregation based upon where the signal was coming from. So it may be that, to my earlier point about you don't always know where the best place to go looking for a signal is, sometimes it may be that you need a combination of areas and that some areas are better for different type of gradings. Okay, and then early this year, we just published some work looking at alcoholic steatohepatitis. So this is people who are have alcoholic or alcoholic, and the alcohol also creates a very similar process. It's a similar pathogenic process where they get inflammation and then disease. So this was actually a pig model we worked on, where we could track biochemical changes associated with grading. So at the moment, Jenny, who is she's a chemistry major, right, Jenny? Jenny is working on combining, she's scanning, we've got a lot of human ash tissues, and she's combining actually with the NASH, because they can be difficult as well. And sometimes you have people who have both etiologies as well. So this is actually a really nice paper. We literally just published it this year, and it's geared towards the interventional radiologist. So it talks a lot about like what is infrared, and so if you're interested in sort of a launching point, it's kind of nice. It also talks about some of the, I'm not going to talk about it today, but some of the work into making this fiber optic based for in vivo work. Okay, well, I haven't done too bad time-wise. So current and future research directions, we are currently working on expanding out the transplant outcomes. One of the projects I didn't talk about, but we're doing with Loyola in Chicago, is one of the big problems with transplant is determining whether an organ is going to be successful. And you don't really want to do surgery if there's going to be failure of the organ. There's also a lot of work saying that we're discarding perfectly healthy organs. There's a very strict criteria by UNOS for whether or not an organ is healthy enough for transplant, so we do discard a lot. So what we're doing, we have outcome information where we have biopsies before the transplant, and then we have outcome information. So we're currently working through scanning those and identifying, is there a signature, or is there something, an image where we can sort of relate this to outcome. One of the studies as well we've just started on this summer, which Michaela Hady's working on, is kind of an interesting project where we have a whole bunch of a lot of tissue. She's poor person's like scanning like crazy, which is kidney cancer patients who are have diabetes and don't have diabetes. What you find is patients who have diabetes have a worse outcome with kidney cancer. So we have outcome information to see which route they go and see is there something biochemically different. We're continuing to finish off the ASH and NASH, and then we've just started on cell and tissue engineering this summer. So I think, well, actually, just let me point out as well, Blake and Katie, who are in my lab, and hopefully some of them are watching that in their dorms. So we just set up this summer the first cell and tissue engineering lab where we've got human cells growing. So we started off with human breast cancer cells. So these are some, you can sort of see the cells. We got 2 HUDs, and we'll be teaching a cell and tissue engineering course next fall. One of the things we're really interested in, so one of the problems with tissue is, particularly in the transplant setting, is it's very dirty. There's a lot of stuff going on. There's a lot of processes going on. Often there's competing diseases. So what we want to do is recapitulate this in a model system and then see, do the changes we observe in a model system relate to what we're seeing in humans? So one of the studies that they were doing over the summer, we're going to be setting up in a new cell line in a week or so, is if you're looking at that diabetic process, if you're looking at how diabetes affects cancerous cells, so we're actually able to do that as a model system in vitro. So just to finish up, So infrared you can couple with computational approaches for automated cell typing and disease, replication and staining, and probably where I'm most interested is identifying biomarkers associated with outcome. There seems to be a really, really big unmet need in the clinical community, and particularly with machine learning. So as I mentioned, we've just got funding through ORSP with Dr. Gomes, where we're going to be using machine learning to better look at kidney cancers and particularly the oncochromophobia and oncocytoma. And if you're interested in more, I have a website. We've actually just got the proofs back, my 50th peer-reviewed paper. We just got the proofs for the last 5 years of all the biomedical research. So this is a particular organ. We literally systematically go through every single organ and every single large study paper. It was a major headache to write. It's about this thick as well. It's in my bag. I'm like trying to put off proofing it before October 1st. So if anyone's interested in that, I can send you the proof for that. But as I said, the JVIR paper, which is actually now online, is really nice for introductions. Also, if you're interested in like this for animal models, we have this nice paper in lung. If you want to see more how physically it works, feel free to reach out. I'm happy to give you a lab tour. We also have a video I did quite a few years ago. It's only 6 years ago, but I look like I'm like 20 years younger. It's really depressing looking at this video of me in the Journal of Visualized Experiments, where we talk about how we actually take measurements on these tissues. And then we had an interesting paper last year, actually, where we were interested in looking at a disease of fibrosis called Scleroderma, which is where you get a lot of deposition of fibrosis. It starts off in the skin, but it then progresses. It's almost like cancer. Actually, it can be caused by a type of blood cancer, where it will deposit in your organs. So we were very interested in see, could we diagnose this and could we predict outcome? And actually, in this case, we weren't able to predict outcome from the current tissues. And part of it was the current standard of care for this. The outcome, it's called the Rodnan skin score, is actually pretty poor. So we don't really have a good comparison. So unfortunately, the professor left. He's now in Michigan and still setting up. So we're hoping to do a longitudinal study where we can track patients over some time. So I want to thank all my different collaborators, ORSP as well for funding and for the Biomedical Innovators Award this year. This is my old lab group, and this is my some of my new lab group as well. So thanks. I'm happy to take any questions. Yeah, that's a good question. We were actually just talking about this last Friday with Rahul. It's a good question. I don't know that there's a good answer yet. So I've served on Department of Defense study sections before, where there's a lot of people doing machine learning of MRI images, CT images. They tend to. I'm never entirely convinced by the power calculations. I think people fudge them. Is this being recorded? Typically, so the general agreement is over 100 patients. Whether that's really true or not, and you need thousands, I'm not so sure. And I don't think anyone's got a good answer to that yet, particularly spectroscopy. One of the ways around that potentially is to sort of, segment out and things and use multiple channels. But yeah, I think minimally you need 10s or 50s, 60 patients minimum, if not hundreds. But yeah, I don't know how I struggle with the thing with writing grants is how do we get like a legit power calculation? And I don't know anyone's figured that out yet. But I think it's something we're running into, and I think that's why people like Google are plugging their Wi-Fi's into the back of a lot of pathology departments and just getting as much data as they can. Because there are certainly things you can do. There are ways to get around overtraining, but it's very, very difficult, and particularly with spectroscopy, where if you're feeding in huge amounts of data, there's always that potential for it to train to something completely random, right? It could be water vapor or something. So yeah, it is one of the problems with machine learning. Yeah, it's a little bit less of an issue if you're doing the image side rather than the spectroscopy side, but yeah. So one way we kind of got around that with the Bayesian is, so with the Bayesian, I kind of alluded to it here. So typically machine learning, there's a couple of ways. You can either just throw everything in and have a really, really powerful, supercomputer or something that can handle this massive, because these are going to be terabytes in size. Or you can do something like PCA at first, which will get rid of all the, we'll only have the variance, and then you can use that, which kind of reduces the computational load. One of the ways that we've done it with Bayesian is we'll only input spectral metrics which are known to be biological in origin. So we haven't very well defined. So if, we throw it in and it comes out and it says, hey, metric number 36 has, an 80% AUC on its own, at least we can go back and see. So that kind of mitigates that a little bit. Whereas, with the machine learning, it's a black box. It could be, it's often impossible to figure out what on earth it's training to. So, yeah. But yeah, it's a good question. Yep.
Since this technology is pretty new, are you building this library so that people can compare their samples, or
that's right.
Is the library already set?
Yeah, we don't yet. So that's a good question. There is a hope to have an online library. So I'm part of a society called the Clinical Spectroscopy Society. It's based in the UK. It was actually funded by the EU until Britain left the EU unceremoniously. They want to create a library that is accessible for everyone. So we put all our data. They haven't figured that out quite yet, partly because EU funding fell through. We're hoping to do that. So I'm actually the co-editor of a Elsevier journal for clinical spectroscopy, and we're the official journal for the society. What we're trying to get Elsevier to do is fund a library banking system, but it's been tricky. With COVID and things, it's been tricky this last year. They're kind of hesitant to fund, but yeah, that's certainly the hope. It's also data sharing as well, kind of to Matt's point about getting enough data. Some of these studies were never going to have enough data for machine learning because there's just not enough patients. I always joke one of the mistakes I made was getting into a lot of orphan diseases where there's just not a lot of patients. So one of the ideas is, well, if we can say, okay, cancers particularly are relatively easy to get hold of. So we can do like an international thing where we say, okay, these are all the breast cancer images. And we've been working, we published a paper last year or 2 years ago in Nature Protocols, which was really geared towards this, was like, okay, we're all going to fundamentally agree on how we acquire our data from the different systems so that we can merge them. Not sure how well that's going yet, but that was the idea. Part of the problem is there's probably 4 or 5 major different systems as well, and they all work a little bit differently. So, but yeah, I agree. I think some sort of database would be very, very advantageous.
Very interesting work.
Oh, thank you.
Do you ever have issues with the pathologists getting on board with this?
It's a good question. I've actually been really lucky in that not so much. I think if they're involved at the ground floor, they really enjoy it. One of my problems has always been that there's too many of them. Like it's always, it's hard to just have enough students like deal with all the projects. If I go to, so I've been to a lot of pathology conferences. If they're not involved, they tend to be more skeptical. And I think there's always that anxiety of, maybe less so from this, but certainly from the machine learning, the image analysis, that they could be, if not replaced, be less needed. Yeah, so it's been very interesting. I've been going to pathology conferences now for probably 15 years, and there's definitely problems. Yeah, so I was kind of interested with this FDA prostate thing being approved yesterday. That's a big deal. I think the hope is it's more of a adjunct, so that, because one of the things is pathology spend a lot of time just looking at normal tissue, like there's reams and reams and reams. And typically for a lot of diseases, they'll have a huge amount of tissue that they've got, but they just don't have the resources to like look at every single slide. So I think the hope is that, well, okay, and this is kind of the prostate one, which is if they can just flag those tissues which have something suspicious and kind of direct them to that. Yeah, but I don't know if, again, it's a tricky one. I have a friend who's a pathologist in Cape Girardeau at a local hospital, and he sends everything to Mayo, actually, that's like, serious cancer, because he just doesn't physically see enough cancers. And it's one of the problems with a lot of the local hospitals, they just don't see enough to, if you get some rare cancer, and that's where the machine learning can, again, really come in, because, Google spent a lot of money, probably Google's the most famous for this, because they've potentially got access to millions of data sets. So they're going to see every permutation, which a human just cannot, or remember. So, yeah, I don't know. It's going to be very interesting over the next 10, 20 years to see how that, I think their jobs are going to change. I think they're much more aware of that now as well. When I started, they were very sort of resistant to it, but I think they've started to realize that they're going to sort of have to embrace it. particularly insurance, because like insurance that's the driver of all of this. And with Obamacare, their reimbursements changed a lot with that. So, yeah, it's an interesting, yeah.
Well, it's 12:50 and you have
Cool.
a class to teach. So thank you everybody for coming. Please join us next week. Next week's forum actually with one of the co-presenters is Dr. Elizabeth Lubowski, who is present here. And it will be Zoom based just for next week. So thank you.
Cool, thank you.
Thank you.
Thanks.